Hello and welcome, everyone. Thank you for attending today. It looks like there's a lot of you here, so that is awesome. Quick introduction. My name is Alex. I am a lupus warrior of 15 plus years now. I'm a volunteer with Lupus Ontario, as well as a facilitator for the men's support group. With that being said, let's get into what this webinar is all about. In this session, Dr. Laura Whittall Garcia will delve into the European Alliance of Associations for Rheumatology, also known as EULAR, and its crucial role in setting guidelines for lupus. She will discuss the current EULAR guidelines for lupus, recent changes to those guidelines, and the reasons behind these updates. Additionally, the session will explore how these guidelines are applied in diagnosing and treating lupus to ensure effective and standardized patient care. Dr. Laura Whittall Garcia is a general internist and a rheumatologist. She joined the University of Toronto Lupus Program in 2019 as a clinical researcher or as a clinical research fellow after completing a rheumatology training and I'm sorry if I butcher this, the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán.
Excellent.
That's good. Dr. Whittall Garcia completed a master's program in medical science with the University of Toronto in June 2023, and she joined the faculty of the University of Toronto Division of Rheumatology as an assistant professor in September of 2024. So before we begin, I just want to let you all know that we do encourage questions. So if you have any, please put them in the Q&A function, and we will get to those at the end for a little Q&A session. And with that being said, without further ado, I will go ahead and pass it over to Dr. Whittall Garcia. Welcome.
Okay. So first of all, thank you so much for the invitation and for the kind words, introduction, Alex. So this first hour, we are going to be discussing the EULAR recommendations for the management of SLE, especially focusing on the 2023 update. So this is the agenda for the following hour. We are going to start by defining what is EULAR, what are the EULAR recommendations for lupus, and why are they important. We will then focus on how have they changed recently and why. And in this section, we are going to highlight three main differences. The first one, the changes in the development of the recommendations, followed by what has changed on the overarching principles, and followed by the differences in the treatment approach that have been highlighted in these recommendations. And for this last part, these 3 points are going to be discussed. The first one is the importance of the minimization of glucocorticoid use. The second one is the importance of the earlier use of immunosuppressives and biologics. And lastly, we will discuss the upfront multi-target therapy in lupus nephritis and why should this be considered. So starting with what is EULAR. EULAR stands for the European League Against Rheumatism. It is an organization in the field of rheumatology that focuses on improving the treatment and care of patients with rheumatic diseases. And the EULAR also organizes scientific meetings, develops guidelines for best practice, and supports research initiatives to enhance understanding and management of rheumatic diseases and musculoskeletal diseases. What are the EULAR recommendations for lupus and why are they important? Physicians often have different challenges when treating patients with systemic lupus erythematosus. Why? Because we know SLE is an heterogeneous disease with heterogeneous manifestations. Physicians also encounter multiple targets, so they have to focus on disease activity, on damage, on comorbidities, on drug toxicity. Also, until recently, for non-renal lupus, there were really no randomized controlled trials. So treatment was and is based on experience. And of course, there's variability in treatment approaches and in outcomes. So the EULAR guidelines for the management of SLE provide evidence-based recommendations for clinicians. And the key points include diagnosis, multidisciplinary care, individualized treatment, monitoring, and the patient education. The guidelines recommendations for the treatment can help homogenize treatment goals. Of course, the treatment will not be the same for all patients because as we have highlighted in these first slides, the manifestations for lupus are heterogeneous and different, so treatment will be different. But if we homogenize treatment goals, then we will improve treatment outcomes. So the first difference is the changes in the development of these recommendations. So there was an effort to reflect practice all around the globe. So in these recommendations, the task force, which is the physicians and individuals in charge of updating these recommendations, not only European were included, 4 physicians from the US were included, 1 from Canada, Dr. Daphne Gladman, 1 from Argentina, 4 from Asia, 1 from Australia. So from all around the world to have to reflect the practice. Now we're going to shift and discuss what are the changes and what has been highlighted in the overarching principles. So in this overarching principle B, what are they stating? They are stating that SLE disease activity should be assessed at each clinic visit. The frequency depends on the physician's discretion. And the evaluation of organ damage should be performed at least annually using validated instruments. Here, I just want to take a minute and just to acknowledge that this that has been recommended right now is the standard of care of what has been done in the lupus clinic, where at every visit, lupus activity is documented and damage is also documented annually. The pioneer work by Dr. Rubitz and Dr. Gladman, acknowledging that detecting or determining disease activity and damage is not only important for research, but also for quality of management of these patients. So why is it important to know and to document disease activity and damage? First of all, what is damage? What do we mean with damage? Damage is a non-reversible change in an organ or a system that can be caused either by disease activity. For example, if lupus causes inflammation in the kidney and that causes damage to the kidney function that's not reversible, then that's damage in the kidney related to lupus. Another way of accruing damage in the body is related to treatment toxicity. For example, glucocorticoids. We know glucocorticoids can cause damage, irreversible damage, cataracts, osteoporosis. And why is it important to document damage? Because damage will bring more damage. Damage will decrease the quality of life and will increase mortality. So it is important to document disease activity and damage. The second point to emphasize in the overarching principle E is that they state the importance of early SLE diagnosis. Having an early diagnosis is a window of opportunity for patients to have earlier treatment and also improve their long-term outcomes. This is a study that was performed by a Greek group. It was published last year, 2023. And what the authors did is an observational study of 275 SLE patients that had an SLE duration of less than 6 years. They found that the median total delay in time between symptom onset and SLE diagnosis was 2 years. So it took a median time of 2 years for lupus to be diagnosed. And that an early diagnosis that they defined as 6 months or less was only achieved in 28.4%. And importantly, patients that had a delayed diagnosis, this was associated with increased damage. So important to be able to have an early diagnosis, to start treatment early and improve patient outcomes. The second part of this overarching principle A also states the importance of having a treatment goal. What's the aim of treating a patient with SLE? We are aiming at remission, or if not possible, at least low disease activity. But what do we mean with this? There are different definitions for remission, but in 2021, this definition came out, and it's the one that has been more widely used. For a patient to be defined as being in remission, they need to have a clinical SLEDAI. SLEDAI is a measurement of disease activity of 0, so no disease activity. They also need to have a physician global assessment, which PGA, which is another measurement of activity of less than 0.5. This goes from 0 to 3. 0 is no activity. 3 is severe activity. Usually patients are hospitalized. Patients in remission can have active serology, so they can have positive DNA or low complements, but no clinical activity. And they are also allowed to be treated, so they can receive antimalarials, Plaquenil, low dose prednisone, so they cannot have more than 5 milligrams, so it's 5 milligrams per day or less, and or stable immunosuppressive medications, including biologics. Now, what is lupus low disease activity state, or LLDAS? This is a less stringent definition that says that patients can have a SLEDAI of 4 or less. So a little bit of disease activity is allowed, but the disease activity has to be stable, not worsening. The PGA should be 1 or less. And once again, patients are allowed to be treated. They are allowed to receive antimalarials, a low prednisone dose, a bit less stringent, up to 7.5 milligrams per day or less. And the same, they can receive immunosuppressive and biologics. And why is it important for patients to achieve remission, or at least LLDAS? Because it has been shown that patients who achieve a sustained remission, or LLDAS, for at least 6 months have less accrual of damage. Now, over the next slides, we are going to discuss in more depth what are the changes in the treatment approach. And these are the 3 points that we had already commented before. So the first one is the importance of minimization of glucocorticoid use. The second one is the earlier use of immunosuppressives and biologics. And the third one, the upfront multi-target therapy in patients with lupus nephritis. So we are going to start with the first one, which is minimization of glucocorticoid use. So this is just to have a bit of context. When a patient with lupus is very active, we are going to give glucocorticoids. Why? Because glucocorticoids, including prednisone, act very fast. They are very effective in reducing inflammation and activity. But the initial dose will depend on what's the disease activity and what's the organ involvement. So it's not going to be the same for everyone. And it may range from 10, 15 milligrams per day up to high doses, pulse IV methylprednisolone in patients with very active or severe disease. And once disease is getting under control, glucocorticoids are tapered down, and they are maintained at the lowest possible maintenance dose, and if possible, stopped. So what does the EULAR 2023 recommendation say? They are saying glucocorticoids, if needed, are dosed based on the type and severity of organ involvement, and should be reduced to a maintenance dose of 5 milligrams per day or less. This is different from what was advised in the 2019 recommendations, where they were a bit more lenient and did allow a glucocorticoid dose of 7.5 milligrams or less. So here they are saying, no, 7.5 is no good. The aim should be for at least 5 or less. And the second part is they are saying, when possible, glucocorticoids should be withdrawn. And why? Why are we so interested in lowering prednisone? Because we know prednisone increases the risk of damage. This is a study that was performed in the early 2000s by Dr. Gladman, Dr. Urowitz, and here they showed the following. First, that damage increases over time. So in this graph, we see that the median SDI is a measurement for damage in lupus. At the beginning of the disease, the SDI is low, around 0.3. But as the disease progresses over time, after 15 years, the median SDI is close to 2. So this is increasing over time. And why is it increasing? They found that at the beginning of the disease, 58% of the damage was related to glucocorticoid damage, only 58. The rest was related to lupus activity. But what happened after 15 years? 80% of the damage was related to glucocorticoids. So the damage that's being accrued, most of it or part of it, is associated to glucocorticoid use. What is this damage that can be caused by glucocorticoids? We know glucocorticoid can cause or increase the risk of cataracts, a vascular necrosis, which is infarcts in the bone, most commonly in the hips, in the knees, but can also be found in other parts of the body. And if it's severe enough, it usually ends up in replacement, joint replacement. Glucocorticoids also increase the risk of atherosclerosis, which is stiffness in the arteries, which increases the risk of strokes, increases the risk of myocardial infarctions. And the dose of prednisone does matter, because as we increase the daily dose, the risk of having damage increases. We see here in this table that patients with a daily dose between 6 and 12 milligrams per day have a 50% increase in the risk of having organ damage. And patients that are taking more than 18 milligrams per day have a risk of more than 2.5. So the dose matters. Furthermore, it has been shown that even doses of 5 or less can be harmful. So there's still accumulation of damage even in low doses as 4.42 milligrams per day. And the chronic use, it has been shown in some studies of 5 milligrams per day, can cause reduction in bone mineral density and increase the risk of fractures. So if possible, glucocorticoids should be withdrawn. This is a study that was, because of this, some studies came out assessing the potential, the possibility of withdrawing completely glucocorticoids. This is a study that was published, was performed by a French group, and they found that patients who abruptly discontinued a low-dose prednisone, 5 milligrams per day, patients that were in remission, had an increased number of clinical flares, 27%, after 12 months of stopping glucocorticoid, compared to those who continued the low dose, 5 milligrams per day, that only flared 7% of them. So this study brought up a bit of panic, but important to comment two things. The withdrawal was abrupt. So one day patients were taking 5 milligrams, the next day they were taking nothing. So it was an abrupt stop. Secondly, only 25% of the patients were taking immunosuppressive medication, so quite low. On the contrary, this is another study that was performed by the Toronto group, published by Costas, Tselios, and Dr. Urowitz and Dr. Gladman. And so they included patients with 2 consecutive years of clinical quiescent disease. The patients had similar characteristics to the patients studied in the prior study that we just analyzed from the French group. They included 204 patients, 102 that withdraw glucocorticoids and 102 that maintain glucocorticoids. The patients in both groups were similar based on their age, their sex, their race, their damage. And the withdrawal was done gradually, so over 9 to 18 months. And they showed that these patients that withdrew glucocorticoid actually had fewer clinical flares and also had less accrual of damage over the following 24 months. What was different from this study compared to the prior one? Well, a higher number of patients were taking immunosuppressive therapy, 47% compared to 25% in the prior study. And also, the withdrawal here was gradual instead of abrupt. So this study at least gives us hope, right? That withdrawal of glucocorticoids is feasible. It's a feasible goal. But we need effective immunosuppressives or biologic therapy to be able to control disease activity and allow a successful glucocorticoid withdrawal. So based on this, we're going to move on to our second point, that is the earlier use of immunosuppressives and biologics. So once again, we have this diagram. And what do we know? What do we need to be able to maintain good control and be able to lower glucocorticoids and possible stop? Well, we need to give concomitant treatment. We know that all patients should receive Plaquenil, and if needed, they should receive immunosuppressives and biologics. This is what the EULAR 2023 recommendations say. So they are saying that in patients not responding to hydrochloroquine, so everyone should be receive hydroxychloroquine, of course, if there's no contraindication, alone or in combination with glucocorticoids, or patients unable to reduce glucocorticoids below the acceptable for chronic use, which is 5 milligrams or less. Addition of immunomodulating or immunosuppressive agents, including methotrexate, Imuran, mycophenolate, and/or biological agents like belimumab or anifrolumab should be considered. This is a graph representation of the 2019 recommendations. So here, just interesting to see what they recommended in mild disease, only the use of methotrexate and Imuran. They left mycophenolate for patients with moderate disease, and belimumab was recommended only in patients with moderate and refractory disease. Now, this is the 2023 recommendations, and we see the dramatic change, right? With earlier use of immunosuppression, even in mild disease, if Plaquenil and prednisone is not enough, patients should be initiated in either immunosuppressive medication like methotrexate, Imuran, mycophenolate, or biologics like Benlysta and anifrolumab. And they are all in the same level. So there's no hierarchy between conventional immunosuppression and biologics. So here we are seeing an earlier use of immunosuppressives and biologics. There's no hierarchy in the choice between conventional immunosuppressive medications and biologics, which in this case includes anifrolumab and belimumab. And the choice would be based on availability, cost, and response to treatment also. The approval of these both biologics was a result of randomized controlled trials with similar extrarenal SLE population. So these recommendations are for non-renal SLE activity. So lupus affecting the joints, affecting the skin, having constitutional symptoms. Over the next couple of slides, we are going to discuss some of the studies that highlighted the importance of adding belimumab or anifrolumab to the treatment repertoire. So we're going to start with real-world studies on belimumab. This first study is the Berlis cohort, which is an Italian cohort that included SLE patients who received intravenous belimumab. All of these patients were refractory to at least one immunosuppressive medication, and they included a total of 466 patients. In this slide, we are seeing the proportion of patients who achieved, after starting belimumab, the proportion of patients who achieved an SRI-4 response. SRI-4 is a measure of disease activity, and for patients for us to say a patient met the SRI-4 means that their SLEDAI-2K should lower by 4 points with no other new disease activity. The SRI-4 is seen in the continuous black line. They also assessed remission, that's seen in the dashed black line, and the percentage of low disease activity in the dotted line. So we can see since the initiation of belimumab, slowly there's an increase in proportion of patients achieving the SRI-4 remission and low disease activity. And just important to highlight that even after 12 months, these percentages continue to increase. So belimumab is a medication that takes a bit more time to act. So even after 6 and 12 months, if you're not sure it's not working, you should give it a bit longer. The authors also found that there was a significant decrease in the incidences of flares during belimumab treatment compared to the corresponding period before belimumab initiation, so less flares. And also the proportion of glucocorticoid-free patients, so without needing glucocorticoid, increased or reached 31.6% after 36 months of treatment, compared to 3.1% at the beginning of treatment. This is a second study that was performed by Dr. Urowitz, published in 2019. In this study, they compared the organ damage progression in patients who received belimumab in the BLISS long extension study, in a study, with patients with similar characteristics that received standard of care, but not belimumab, from the Toronto Lupus cohort. And they found that patients receiving belimumab had significantly less organ damage progression compared with patients receiving standard of care. So what have we learned from these real-world studies on belimumab? That belimumab can increase the percentage or proportion of patients achieving remission and low disease activity. It can lower the number of flares and decrease the damage accrued. Now we're going to discuss some of the clinical trials for anifrolumab and how this medication was finally accepted and incorporated into the clinical world. The first phase 3 randomized control trial that assessed the efficacy of anifrolumab is TULIP-1 study. So a phase 3 randomized clinical trial is the last set of studies after which if we have a positive result, then the study would be approved to use in the clinic. So in this slide, in panel A, we are seeing the proportion of patients who achieved an SRI-4 response that we talked about it in the prior slide, which is a measurement of response to treatment. In panel B, we see the percentage of patients who achieved a CLASI response. CLASI is another measurement of activity, but focuses on the skin. And in panel C, the BICLA response. So this is another measurement of activity as SRI-4, but instead of anchoring on the SLEDAI, it anchors on another measurement that's called BILAC. But in nature, they will measure the same. This is activity of lupus. In this first set of analyses, the authors didn't find difference between patients receiving anifrolumab and patients receiving placebo. Anifrolumab in red, placebo in blue. Just to comment, placebo means that they were not receiving anifrolumab, but everyone was receiving standard of care. So everyone received treatment. But interestingly, in this first set of analyses, 8% of the patients that received non-steroidal anti-inflammatory medications, for example, naproxen, ibuprofen, were classified as non-responders, and the authors didn't find differences. But what happened with this amendment rule? So these 8% of patients that were classified as non-responders was switched to responders. Now we see a difference. So 57% of the patients who received anifrolumab achieved a CLASI response compared to 43% on the placebo group. Also, the differences for the BICLA response was significantly different. 46% in patients receiving anifrolumab achieved a BICLA response compared to 30% in the placebo group. Unfortunately, because the primary outcome for TULIP-1 was SRI-1 and there was no difference, this first trial was deemed negative. But the story doesn't end there, because then the second phase 3 trial, TULIP-2, came out. And here, the main outcome was BICLA response. And we see that there was a significant difference, 47.8% in red on the patients receiving anifrolumab achieved a BICLA response compared to 31.5% in those receiving only standard of care. So this was a significant difference and was a positive study. So based on this, anifrolumab was accepted for use in SLE. And this is a pooled analysis. So they altogether included patients from TULIP-1 and TULIP-2. And I just want to highlight the capacity of anifrolumab to lower prednisone, because as we have been discussing, being able to lower prednisone is also an important outcome when we are treating patients with lupus. So in the dark lines, we are seeing the CLASI response. So CLASI is the activity in the skin. In red, the CLASI response for patients receiving anifrolumab, so 46% of the patients had response, compared to only 25% of the patients receiving standard of care. And in the lighter lines, we see the decrease in glucocorticoids. So in the light red with the triangles, we see the decrease in glucocorticoid use in patients receiving anifrolumab, and how this is different from patients using only standard of care that we see in the light blue. The percentage of patients with a glucocorticoid reduction target that was less than 7.5 milligrams was higher in the patients taking anifrolumab, 51.5% versus 30.2% in the placebo group. So what did we learn from these anifrolumab trials? That patients taking anifrolumab had achieved higher percentages of response to treatment, and also were more successful in tapering glucocorticoids. So now, over the next 10 minutes, more or less, we're going to discuss the last part of the talk, which is the upfront multi-target therapy in lupus nephritis. So previously, we had been discussing treatment for non-renal lupus, and here in the last slides, we are going to discuss the treatment for lupus nephritis. So the EULAR 2023 recommendations state that patients with active proliferative lupus nephritis should receive a low-dose intravenous cyclophosphamide or mycophenolate and glucocorticoids. This is the standard of care. All patients should receive this. But they also say combination therapy with belimumab, either with cyclophosphamide or mycophenolate, or calcineurin inhibitors, like voclosporin or tacrolimus, combined with mycophenolate, should be considered. Here is also the graphical representation, where we see at the top all patients glucocorticoids, all patients Plaquenil, the standard of care, which is mycophenolate or low-dose cyclophosphamide, and then adding upfront, since the beginning of the treatment, the possibility of combining treatment with belimumab or with calcineurin inhibitors. So why has this changed? What is the evidence suggesting that this should be done, and why should we consider doing it? So we know that with the current standard of care, up to 30% of the patients will not respond to treatment, and 30% of the patients will have subsequent lupus nephritis flares. And patients that don't respond to treatment or have subsequent flares have an increased risk of end-stage renal disease. Here is a graphical representation of the GFR. eGFR is a measurement of kidney function. We see in blue what usually happens to the kidney function. Usually after 40, 50 years age, the kidney function slowly starts to decline. That's something that happens to everyone, regardless of disease or not. But what happens to someone who has a lupus nephritis flare? This kidney function, GFR, that started normal at 120, just in this first insult, goes down to 60. And if you are able to control the disease and avoid future flares, things may not be as bad, but the patients will still have a slow decline in the kidney function over time. But what happens if the disease is not controlled, or if they continue to have lupus nephritis flares? Well, this kidney function, the GFR, will continue to lower. So patients are at risk of developing end-stage renal disease very early in their disease course. So what needs to be done to preserve kidney function? We need to have better and faster control of lupus nephritis activity. And two, we need to avoid further flares. Over the next slides, we are going to discuss what's the evidence behind the EULAR 2023 changes in treatment for lupus nephritis. And we will focus in two things. First, the phase 3 belimumab lupus nephritis clinical trial and its post-hoc analysis. And second, the phase 3 voclosporin clinical trial, which is a calcineurin inhibitor. So this is the phase 3 clinical trial where belimumab patients with lupus nephritis were treated with belimumab and standard of care, 223 patients, and another 223 patients were only treated with standard of care, no belimumab. The outcome to say patients responded or not to this treatment was the primary efficacy renal response. What do we mean by this? It means that patients, to be able to say they had a response to treatment, their protein in the urine has to be lower than 700 milligrams per day, and their kidney function shouldn't be more than 20% worse compared to their initial kidney function, and no rescue treatment for failure. And they found that patients that received belimumab had higher percentage of response, 43% compared to 32% in those only receiving standard of care. They also looked at a more stringent outcome, which is complete response. In this case, instead of 700 milligrams of protein, patients need to achieve 500 milligrams per day or less, and they are a bit more stringent with the kidney function. Once again, patients that received also belimumab achieved greater complete renal response, 30% compared to 20% in those with standard of care. And what about the post-hoc analysis? So it was analyzed to see if belimumab had an effect on future lupus nephritis flares and or decline in kidney function. So they found that patients that received belimumab had lower rates of lupus nephritis flares. So only 14.4% of them flared compared to 26% of patients treated only with the standard of care. They also assessed the effect of belimumab in the decline in kidney function. So they assessed sustained 30% and 40% decline in GFR, the kidney function. And here is just to highlight, what does this mean? Is this significant? So if we say that someone has a normal kidney function that is more than 90, if they have a 30-40% sustained decline, this means that only with the first insult of lupus nephritis, their eGFR will be lower to 40-30%. So this is indeed significant. And they found that patients that were treated with belimumab had lower percentages of achieving this decline in kidney function compared to patients that were only treated with the standard of care. So belimumab may be especially helpful for patients who have had previous lupus nephritis flares or who have impaired kidney function. And this last study is the voclosporin study, which is phase 3 trial to assess the effect of voclosporin in lupus nephritis. Voclosporin is a calcineurin inhibitor. 179 patients received voclosporin in addition to standard of care, and 178 received only standard of care. The percentage of patients who achieved complete response, that as we were discussing, complete response is achieving a protein in the urine of 500 milligrams or less, was greater in patients receiving voclosporin, up to 41% after 1 year, compared to 23% in those receiving only the standard of care. And they also found that the time to decrease of proteinuria was much faster in patients receiving voclosporin that we see in the blue line compared to those on standard of care that we see in the red line. The median time to achieve a proteinuria of 500 milligrams or less was 5.6 months compared to 12 months in those with standard, only treated with standard of care. So the control of the proteinuria is much faster, which allows also for a faster reduction of steroid. Now, why is voclosporin and other calcineurin inhibitors like tacrolimus so effective in reducing protein in the urine? Because these kind of medications have two effects, dual effect. One, we know it has an immunosuppressive effect like mycophenolate, like prednisone, but also it has an effect directly to the kidneys in the cell. It stabilizes their function, so improves the proteinuria faster. So these kind of medications is especially helpful in patients that have very heavy, very high proteinurias. So to conclude, the main aim when we are treating patients with lupus is to prevent damage. We want to prevent damage. How do we achieve this? One, having an early diagnosis. One, having an effective control of disease activity. 3, preventing flares. And 4, minimizing glucocorticoid use. And how are we able to achieve this? We need early use of immunosuppressives and biologics that are effective to control the disease. And in patients with lupus nephritis, we can consider multi-target therapy. So just to finalize, we are seeing this shift in paradigm, these changes in treatment, where we are giving immunosuppressive therapy earlier, that's more effective to treat lupus. And I envision that this will continue to change because in just the last couple of weeks, we have had 2 extra positive phase 3 clinical trials for the treatment of general lupus and also lupus nephritis. So for sure, this will continue to change over the next years. So thank you so much for your time. And if you have any questions, I'll be happy to answer.
Well, thank you very much, Dr. Whittall Garcia. A lot of good info there. And thank you to Roche, who is our presenting sponsor, for your support. We have a few questions here. I'm just going to read them out loud. So the first question, what efforts are being made to support an early diagnosis in more patients?
Yes, so the increased awareness of the disease, I think what's the main goal here to achieve awareness, not only like in general practitioners, in all physicians. Why? Because if there's an awareness and we know, or general practitioners are aware that of possible manifestations, then they will be referred sooner. And if they are referred sooner, hopefully they can start treatment earlier, right? So I think that's the main goal, to have awareness, and the physicians that should be targeted and are being targeted are general practitioners, also orthopedics, right? That it's not uncommon for someone with joint pain to be assessed first by an orthopedic surgeon.
So yeah, just going off that, normally at what level is your EF or your GFR flagged?
Yes, so that's also an interesting topic. We also know that eGFR is not perfect, right? Because
Mm.
for us to start seeing a decline in EGFR, it means that a lot of the kidney is already lost, right? So we like to avoid at all degree any decline in EGFR. Even a minimum decline. If we say, okay, 90 is still a normal range. Yes, but if we are seeing 90 in a 20-year-old, it's not as normal, you know? So we have to always to be aware. And of course, we see EGFR. It's a study that we do every time we see a patient. But we have to keep in mind that if we see changes in EGFR, it may be too late, right? We want to attack or prevent right before we see any change. So I would say any change in EGFR should be flagged.
Okay, yeah. Okay, makes sense. Another question here. How do rheumatologists work to reduce the risks that are associated with glucocorticoids in patients who can't get off the medication?
Yes, so it's true. There are some patients that it's hard to get off because of non-response to treatment or because there's side effects to medications. But there's always this discussion, right? That we always have to balance the benefit versus the risks of all medications. And it's always an active discussion in the clinic. And our aim is to achieve a taper. So if we cannot taper because lupus activity reappears, then we know the base treatment is not enough, right? So either we have to change it to something else, we have to add something else. So we have the responsibility to change and achieve a good control of the disease so that we can taper glucocorticoids.
Right. Um, we have another one here from someone who's been working with Lupus Ontario for a long time, but they've only heard in the last few years of EULAR. Does this mean that more information will be flowing from Europe and Canada and the US?
Yeah, so true. But in rheumatology, we have like two big groups, to say so. The EULAR that comes from Europe and the ACR, the American College of Rheumatology, that's more from North America, right? And both groups are very actively involved in lupus and other rheumatologic conditions. There are also guidelines for treatment that come from the ACR, from the American College of Rheumatology. But I think both complement, right? And as I exposed on the first slides, this time the EULAR also tried to make it broader, right? And to include other physicians, not only saying we are Europe and we are working alone. So because at the end we all see the same patients, right? So it is important to learn from one another.
Yeah. Okay. Um, Sorry, I'm just trying to read these. Have someone here has been taking Benlysta infusions for the last 6 months, and the rheumatologist said that the medication will continue until next year. Is there any support group for free drugs or subsidies? It's getting pretty expensive.
Yeah, absolutely. I think that's one of the biggest limitations with biologics, right? The cost. And of course, I mean, we would never want to for someone to go into bankruptcy. We can always look for other options. There are always other options because at the end, I mean, the patient is a whole, right? It's not
Mm.
only take this and then see how you're going to pay. So unfortunately for Benlysta, currently, the way to get it, because it's too expensive to pay out of pocket, is either having an insurance, medical coverage. Also, currently, the government like would pay for it if we apply in the cases of lupus nephritis. So we are able to argue and get it, yes, if it's in the setting of lupus nephritis. Well, we're currently on the way and trying to get it for all lupus, like is the case of anifrolumab, that CADE did approve anifrolumab in the treatment of general lupus. For Benlysta, belimumab, this is not the case. So unfortunately, if there's no a drug coverage, or if it's not associated to lupus nephritis where the government will step in, there's no other way to get it. And yeah, and Benlysta is a medication that usually is giving on the long run, right? So only giving it for 6 months, only for 1 year, like may make a difference, but it should be thought of it as a medication for the long run.
Right. And just in saying that, your patients, do the majority of your patients have challenges in paying for the recommended treatments?
Um, yes, I because not only Benlysta and anifrolumab are expensive. Like, of course, those are like off the charts, right? If you don't have insurance, you cannot pay. But other medications, for example, mycophenolate, that is a medication that has been on the market for decades, right?
Hmm.
And it's being used for a very long time, not only for lupus, but also, for example, for renal transplants. And it's very important for us, like it's one of the most effective medications. It's quite expensive, right? If you think about it, more or less per month, the cost of mycophenolate is around $400. So it's not inexpensive. There are ways of going around. Trillium can sometimes help to cover the cost. But I think it all adds up, right? Because it's not only we're talking mycophenolate and then we are adding the Plaquenil and the glucocorticoids. So I think all of these does add up, and it's challenging for patients. So yes, absolutely. I think this is a big challenge.
And okay, so sorry if I'm having difficult pronouncing this. It's anifrolumab?
Anifrolumab, yes.
Anifrolumab. Okay, so we have a question here that's saying anifrolumab has public access in Ontario for non-renal lupus.
Yes.
How do you choose between biologics?
Mhm. Yes. So in between biologics depends, as I was saying, also availability, right, of medications, on the manifestations. So, for example, anifrolumab has been shown to be very effective for skin. So patients that have a very active skin disease, probably anifrolumab would be a better choice. And that's in between biologics, right? Um, Benlysta, there's no, like anifrolumab, like there's no government access, as it has been stated correctly, but there is for lupus nephritis. And anifrolumab, there up to now hasn't been proven to be effective for lupus nephritis. So if we are talking about lupus nephritis, which is a different manifestation,
Yeah.
of course, adding belimumab has much more, like it's something that you could do instead of adding anifrolumab, right? So it depends on the clinical presentation, the organs that are involved, and availability. Always important availability, because at the end, I mean, you don't gain nothing, only stressing, right? Saying, oh yeah, you need this medication, but if you can't get it, then, well, let's see how you do. No, there's always options, right? We can always try treatments.
I have been through a lot of options in my treatment. Um, I have a comment here from Heidi just going, I know a lot of you are asking about prices, but she said when she didn't have coverage for her drugs, she looked on the manufacturing pharma company website and asked for patient assistance. And she said this is a good option with some companies, but not all of them. Okay, one more question here. For LN induction, any points of considerations for when you would consider RTX upfront as opposed to using combination therapy?
So rituximab upfront?
Yeah.
Okay. Um, so rituximab is also a medication that we give for lupus nephritis. I would say upfront, like if it's the first episode of lupus nephritis, I would rather go with combination, for example, mycophenolate and belimumab than rituximab, because there's more evidence of its efficacy. Mhm. If, for example, there's it depends also on the patient's characteristics, right? So, for example, if mycophenolate cannot be tolerated, because we know some patients just don't tolerate it, has sometimes a lot of gastrointestinal symptoms. So if it cannot be tolerated, um, and for example, it's a young woman that is looking, or it's very important for her to maintain fertility, and we know cyclophosphamide, which is another option, can sometimes impair fertility. So in these cases, maybe rituximab, right? Like you could consider rituximab as induction. So I think it depends a lot on the patient characteristics. The scenario, it's very different. Yes.
Okay. And we have one more question here from Nadia. She's saying the nurse at the Lupus Clinic in Bathurst Hospital also confirmed that she has borderline lupus. Her previous results indicated lots of symptoms of Sjogren's. Hence, she's only taking her psychiatrist medication for resting, but she stopped Imuran, Plaquenil. So she's wondering if there is something that she could ask her family doctor this week.
So I think if there's been now like a diagnosis of an underlying autoimmune disease, if it's Sjögren, if it's lupus, I would strongly recommend her to be followed by a rheumatologist. So I
Hmm.
think her family physician should refer her to a rheumatologist just to be sure that she's receiving all of the treatment, right? That needs to be given. Corroborate diagnosis and be sure that she's receiving the treatment that she needs.
Agreed. Yeah. And then I just have one question for you. I know when you were talking about steroids and you mentioned there's still damage being done at the 5 mg level and even at the 4.2, I think you said.
Mhm.
What about lower? Is that something that's been tested, like say being on 2 mg or even 1 mg, or is it even effective at that point?
Right. Yeah. So, I mean, I cannot recall a study that has shown, right, if there's any damage at 1 or 2 or 3 milligrams, but I can tell you by experience, and you may think 2 milligrams, 1 milligram, what effect can that have, right? But when you are tapering down, when patients are tapering down, and some, right, when they go down to 3 or 2 to 1, they tell you, oh my God, I feel so different. I've continued to lose weight. My blood pressure is better. So even low doses have some impact. I
Hmm.
do believe that even low doses have an impact.
Hmm. Yeah. Okay. Okay, well, thank you very much for the presentation. I'm sure everyone here enjoyed it. There was a lot of questions, and this is all going to be recorded and put online. So thank you very much, Dr. Whittall Garcia.
No, thank you very much for everything.
Of course. Thank you.
Thank you. Bye.